Hello, everyone, once again. From the chest wall to the airway, this is a little bit longer talk than the previous one, and I will try to run through this one because the surgery of the airway encompasses quite a bit of stuff, and we will see how much we can cover in the next half an hour. So when we are talking about the airway, the the main thing is airway obstruction, which comes to mind, and there are various reasons for airway obstruction. And uh, when we try to look into it, could be fixed obstruction, which is commonly which we see, and it could again be benign or it could be malignant. And malignant again are either lung cancers which are invading the major airway, or it could be primary tracheal tumors. And when we talk about benign, the post-intubation and the post-tracheostomy have almost, I would say, disappeared, but you still see them not too commonly. But this idiopathic subglottic stenosis is something which is becoming more and more common, or probably it is what we are seeing because they get directed to certain places, people who have some experience with it. But this is something which I will discuss a little bit more detail later on. And then you have other rare problems like granulation tissue or a blood clot or some foreign bodies. And then there is another one which is becoming a problem, actually, I would say, a dynamic airway obstruction. And this is something which probably will require another lecture and something which I would implore everyone to get involved with because we really don't know how to deal with this particular problem. And then there are certain functional cases. So when we talk about investigating these patients, so if they have got a acute stridor, I don't think you'll have a time to investigate, but then majority of time patient will have some investigation performed, and majority of them will have either bronchoscopy or they would have a CT scan. And CT scan is quite useful because it gives you a roadmap before you as a surgeon put a rigid bronchoscope in. It tells you whether the obstruction is intrinsic or extrinsic, where is it, what are the dimension, and most importantly, what is the distal patency of the airway like? Because that is very, very important. Not only it gives you confidence to undertake any diagnostic or therapeutic procedure, but also what are you going to tell to the patient before you undertake that intervention? And what is the relationship of that lesion to the surrounding structures? And further investigations, like whether you want to do EBUS to make a diagnosis, or you want to take a spirometry and flow volume loop, depends again what the cause of airway obstruction is and how acute or the problem is. So the initial management, and particularly in the patients who have acute airway obstruction, is that you must recognize that the patient is having critical obstruction. This is important. I'm put it as number one because even if you have 1 or 2 millimeter size airway lumen and you are sitting, you can still shift air in and out. But the problem will happen when that 1 or 2 millimeter airway gets blocked with secretions, and that will make it really catastrophic. So if patient is having a narrow airway, recognize that that is critical and needs to be sorted out. And the patient is symptomatic, various maneuvers you can do, but nothing beats giving patient a calming atmosphere, talk to him nicely, and make sure that you actually make his, because it's very, very difficult for a patient who can't breathe air in. He'll become more and more anxious and will try to hyperventilate, and all that starts a vicious circle where it um, ends up in a bad outcome. So calming a patient down and even giving a bit of a sedation is a good idea. And then humidified oxygen or heliox helps, gentle chest physiotherapy. And very, very rarely will you need any urgent intervention, and that includes intubation. And I would say beware of intubating a patient who has got a critical airway obstruction, because that 1 millimeter size airway will become completely blocked if you try to shove something through. So make sure that you have an experienced person who can do that, or avoid doing that. And very rarely will they need any intervention. As I said, majority of them will respond to this management plan. And these are the tools which, if you want to dwell in the airway work, or even if you don't want to, you're a thoracic surgeon, you should be have these few of them, particularly this ordinary rigid bronchoscopes and the various kits to ventilate through it. But if you want to develop the practice, then these other sophisticated bronchoscopes of various sizes and the tracheoscopes and will be of use, and particularly these graspers and biopsy forceps and the Hopkins telescopes are something which are, I would say, essential. And then dilators, and then this laser machine, if you can have it in your armamentarium, then even better, because they are useful. And then the most useful thing is the anesthetist. So you need a good anesthetist who has confidence in you and you have a confidence in him, because these patients are quite sick. They may not be able to lie spine. They may have to be induced sitting down position. And again, avoid patient getting anxious, avoid patient coughing, and then trying to give no paralyzing agent if possible, till you are very confident you will be able to get and secure the airway. And beware of loss of airway during induction, because that is a disaster. You don't get time to really do much if that happens, because the patient's already sitting at the edge. And once you have got the airway in and you're trying to ventilate, make sure that dynamic hyperventilation doesn't happen, because that will not only make patient hemodynamically unstable, but can cause other problems as well. Once you have done a good job, make sure that you don't go and start drinking coffee in the coffee room, because quite a number of these patients can redevelop obstruction because of some secretions or stuff lying further distally starting migrating upwards. And talking about the tools, this is again something which is important. The high flow oxygen we've been trying to use in certain cases, and this is a jet ventilator, and this is the ordinary venturi which we use with the rigid bronchoscope. And also we have attempted many a times, if you have got a good blockers, to use a conventional circuit through the bigger scopes. So when we are talking about airway surgery, I'll start with the palliation, because that's the easier one to deal with. So you'll find these patients with advanced cancer blocking the airways and resulting in either collapse, consolidation, or patient actually becoming symptomatic and struggling to breathe. And it is important to get this airway, this lung opened up, get rid of the secretion, because the only hope this patient to live little longer is to have systemic treatment. If this is infected, then that will not be given. So it is important to get rid of this obstruction in the left main bronchus, let the lung expand, and the guy goes and have further treatment. And this one, obviously, you can imagine, it'll be so difficult for him to breathe and to die with that sort of a feeling that somebody is going to strangulate. Is a bad way to go. So this is something which gives a very gratifying results if you can go through the tumor and give a good patency to the airway. And this is what it really looks like, and blocked airway, and you can easily, with a laser or with a cautery or with any other means, you can go through the tumor. So the aims for palliation is that you improve the clinical symptoms and quality of life, and that relief from strangling sensation. And then you can allow other treatment to be given. So the laser is what we use, but again, people can use whatever instruments they have or whatever means to disobliterate the tumor you can, but make sure whatever you use, it doesn't bleed. Because once it starts bleeding, with the airway already narrowed, with a lot of secretions lying distally, things can become catastrophic. So whatever you use, make sure it remains bloodless, which is very difficult, particularly with sarcoma metastasis and particularly with melanomas. And then once you have opened the airway up, or if there's extrinsic compression, then you may have to use stents if the airway doesn't remain having a good patency, and then you need to insert a stent. So any airway obstruction where you cannot actually perform a surgery, you can insert a stent, and as I said, adjunct to ablative procedures or in tracheoesophageal fistulas. But just remember, the stents is a disease, okay? So it is not to be used in somebody where the person is going to be alive for more than few months, because it will create its own problem. And also beware that to insert the stent, particularly as you go further distal into the airway, it's not very effective. So you should not be really stenting anything beyond the main bronchi, because it will eventually block. And these are the various stents. It could be non-metallic ones or it could be metallic ones. And the non-metallic one, this is the gold standard, the Duman stents, and they work fantastically well. The only problem with these stents are they're a bit fiddly. They have to be reloaded every time, and then you need some sort of delivery system, and then you need a bigger bronchoscope for that these to be delivered. And these are Montgomery T tubes. Again, if you are practicing airway surgery, you should be aware of these ones. And they're fantastic, particularly somebody who needs a long-term um, stent insertion. And then there are metallic, covered or non-covered. And I'm not going to go into the details of this, but just to let you know, the non-covered ones, although physiologically may be better, but then they get sort of embedded into the tissues and can be very difficult to remove later on. And when you are talking about the stents, as I said, or lasering the airway, you must make sure that there's a good distal airway, and then you should be aware, do you have a landing zone? Okay, so where is the tumor in relation to the cricoid? You can't actually put a stent if it is that area, because you need a landing zone. And similarly at the carina, what are you going to do? The carinal ones, are you going to put a Y stent, or you put a sort of two stents on either side? So these things you need to know before you put the patient on the table. And this is the normal way. I've tried to just make a diagram to demonstrate how you put these stents in. So you get the stent, you load the stent in the delivery system, and then you, through the bronchoscope, through the rigid bronchoscope, you have gone past that obstruction. These are probably the teeth of the patient I've tried to make. And then you measure the distance from there to the obstruction, and that distance is what you will push the delivery system through. And once that is where you have reached, you deploy this stent. Okay, so the way the stents are deployed, all these silicone stent is that once they are loaded, you actually pull the outer tube out. The stent stays exactly where it is, and as you're pulling the tube out, it just opens up and it gets deployed there. And that's how you deploy them. And it is completely, and this is important because the delivery system is going to be quite big. You cannot put a bronchoscope along with this one. So you have to really go by the measurements. So once it is deployed, you can either pull it out, or if you haven't deployed it properly, you have to completely pull it out and redeploy it. But if it is lying somewhere further distal, then pulling it out is not a problem. So advice is deploy it little distal and then you pull it out and position it nicely. Whereas the the metallic ones, because the way they are loaded, the delivery system is not more than few French in size, and then it's very easily you can put it alongside the flexible bronchoscope, and you can deploy it actually under vision, looking through the flexible bronchoscope. And that's how we do it. And rarely, we never required any radiology guidance to place these stents. So this is a example which I showed you. So this is a patient who had a tumor there, laser debulked it, and then you placed a silicone stent higher up in the trachea, and you put a Y stent in the carina, as you can see here. Or you can put a separate 3 stents in the trachea, or and 2 separate stents in the main bronchi. So this is another example where you have actually put a stent, and this is a Duman stent, and you have made a hole actually just corresponding to the right upper main bronchus. And this is another example of the 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 Montgomery T tube. Here, the patient has a tracheostomy for a long time, and you can see the shelf being formed here. And so what we did was that we put a T tube through here, and this T tube has pushed this shelf forwards, and you leave it for some time, and then this will remodel itself. So there are a variety of ways you can deal with these problems, and you learn over a period of time what suits you the most. So once the stents have been placed, as I said, beware of redevelopment of the obstructions. Make sure you have a chest X-ray before you discharge the patient, because they can migrate. So you know where you have placed them and you can monitor them. And make sure these patients are well hydrated, because the mucociliary reaction is gone and they get very easily coated with the secretions and can cause problems. And these are the problems which nobody wants to see. One is that these metallic stents, they get completely encased into the tissues, and at the ends there is intense fibrosis, and that causes restenosis, and that becomes a problem. How you deal with that? So you can dilate it and put another stent through to remove it. It's a problem. Or you can get this sort of a granulation tissue. Can you imagine that patient has got a blob of granular tissue and you don't know how the patient is breathing? Or you get this, which you never want to see, that patient actually has developed a fistula, tracheoesophageal fistula, as a result of a stent eroding through. And these are the complications. And this is how, if you have to remove this metallic stent, it'll come out like that. So if you have to put a long-term stent, either do a tracheostomy or you put a Montgomery tube, okay, that is much better, or you put a silicone stent, or you put a covered stent. So non-covered stents will be a problem. Okay, so that's what I just have said. And if somebody wants to make money, find a stent which is an ideal one. And people have tried absorbable stent, but they have, again, not really worked. So curative. So when do we deal with the airway problems with curative intent? And again, benign tracheal strictures are the common ones. Okay, as I say, although the incident has gone down quite a bit, but you still see those cases. Then there are some tumors which are resectable, fistula, and last is EDAC. If you have time, I'll discuss that with you. So the benign strictures can be anywhere: subglottic, at the site of the stoma, at the site of the balloon, at the site of the tip, and they can be anywhere. The benign strictures which used to happen with intubation are rare, but we still see them, and we see them actually because these are normally low pressure cuffs. They don't cause strictures anywhere else, but if somebody inflates it in this area, they will cause problems. Okay, and that's what we are seeing. And this is a classical post-intubation strictures. That's what they look like. And the colleagues who want to start on the tracheal surgery, this is the ones you should really look on. Something like this, far away from the vocal cords, a really small area, very gratifying results. And these are the typical post-tracheostomy strictures. You can see the cartilages being damaged, and this is exactly A-shaped or inverted V-shaped strictures which are common. But then we have seen quite badly damaged cartilages appearing in various fashion, and here actually the trachea is completely transected. And these are the ones which, again, I think we all need to collaborate, because these are a really difficult beast to treat. These are young women, 40 to 50 years of age, with no previous history of surgery or any trauma. They develop this subglottic stenosis. And where they develop is at a very wrong place. And by the time they come to you, they would have been dilated, lasered few times. And what that does, what any dilatation does is it causes fibrosis, and fibrosis is not only circumferential but longitudinal as well. And the longitudinal, as it comes more towards the vocal cord, the area where you're going to resect and create an anastomosis disappears, and that becomes a problem. So the surgery is difficult because of the relationship of it with the cricoid and the vocal cords and the recurrent laryngeal nerves. And if you are messing up with the vocal cords, you will have problems later on. So you can see these patients, for example, this one and this one, they have been sort of not badly managed, I think managed correctly, but probably should have come to an appropriate center a bit early. The other thing is these patients, you must biopsy them all the time, because polyangiitis granulomatosis is another condition where you can see these sort of pictures. And then there are certain congenital ones. So this is a thin membrane congenital, present congenitally, and patient treated for brittle asthma for ages. And all we needed to do was to shove the bronchoscope through it. It broke that membrane, and patient was cured, had a different lease of life. So what do you do with them? You need to do a proper assessment for these benign strictures, okay? Even the one which I showed you, I said, go ahead and operate. That's a simple one. Just don't jump in. You need to know a lot of things. You need to know, are the vocal cords competent? You don't want to do a good surgery and you find actually there was one vocal cord working, the other one you have buggered it, and now the patient has got the vocal cords lying in a median position and the patient can't breathe. So make sure the vocal cords are competent. You must know where it is, yeah, but more importantly, are there any other areas which are narrow? And this is a classical example. There is a narrowing here. This is a post-tracheostomy stricture, but also there is a narrowing at the tip of the tracheostomy tube. Okay, so you need to know that before you jump in to do anything. And look at this one. This patient had further supraglottic problem as well. Okay, so make sure that you know where it is, what is the extent, can you take it out and re-anastomose? What else you need to take out? You take this out and that problem persists, you haven't done anything uh, good for the patient. And how bad it is. Okay, if it is 50% narrowing in somebody 80 years old, leave him alone. He's not going to run a marathon, and 50% luminal patency is good enough for him. So what do you do? Do you dilate or you resect? So I think there is no question about post intubation or post tracheostomy stricture. You dilate them once and they come back, just go ahead and resect them. That's a better option because the results are good. The surgery is relatively easy. But what about the subglottic ones, which are already a complex reconstruction? You need to take the cricoid out. You need to do some sort of fissurectomies posteriorly or anteriorly. Do you want to give such a complex surgery to the patient? So my approach has been that dilate them few times and see what is the length of time patient doesn't come back to you. What is the frequency? And how many times you're dilating them in a year. Somebody who needs a dilatation every year or every 2 years, I will leave it alone. And I have anecdotally, and I'll probably look into this big number we have. We have seen that you dilate 5 to 6 times, and if patient has to settle by that time, it will settle down. But if it doesn't, then you need to resect it. But if somebody is coming back to you within 2 weeks or within 3 weeks, then that patient, I don't think, can be sorted out with dilatation. And in that case, you should seriously think about resecting it. The other thing about the dilatation is be very, very careful. Do not overdilate it. And this is the subglottic stenosis. I always recommend to use not anything bigger than 16 millimeter diameter balloon or even smaller. So be gentle, be conservative, do not overdilate because, as I said, the fibrosis will cause longitudinal fibrosis and damage as well. And that is not good for these patients with just stenosis under the vocal cords. Okay, so make sure you are conservative and you use your dilatation judiciously. And if the patient is coming too frequently, think about resection, send it or ask somebody to come and help you to do these cases. And if nothing can be done and patient is deteriorating, then do a tracheostomy because these are the patients who will not uh, survive if they'll end up in a A&E and somebody tries to intubate them. So surgical consideration for these is that if it is post-intubation, post-tracheostomy, let the inflammation subside and make sure that actually you recapture the tracheostomized trachea. Okay, and this can be easily done. And then make sure you have assessed the patient nicely. And this is again important. Again, I'll just keep stressing on this. Make sure that you have done a nasal endoscopy to see the vocal cords and make sure that the larynx is not collapsing or malic, right? And this is a question always asked, how much you can take it out? I think it's your judgment. It depends on how much fibrosis is there. Somebody having had bad tracheostomies, you may not be able to take out 2 centimeters of trachea out, but in a normal person, you can probably take out half the trachea, 4 centimeter without any release maneuvers, and another 1.5 to 2 centimeter can be captured with the release procedures. Almost all the tracheal problems can be dealt with from cervical region. It is only lower third of the trachea. And in fact, I would say about anything which is more than 1.5 to 2 centimeters above the carina will require you opening the chest, either from front, median sternotomy, or high thoracotomy, a third space, right-sided thoracotomy. Do you need to dilate a patient before the procedure? Yes and no. If you are using a laryngeal mask, you don't need to. But if the anesthetist is not confident to use laryngeal mask, then you may have to dilate it very gently and then put a smaller reinforced tube. Position the patient. You will need a shoulder bag. You need to extend the neck, and then you also need to make sure that when you are connecting the two ends together, somebody takes them out. So be prepared to put a shoulder bag and to remove it without disturbing your sterility and without disturbing your sutures and stuff like that. So you need to work around that. How you do that? How you ventilate the patients? Jet ventilation has lots and lots of advantages, and if you have one, it will help you to keep operating without apneas or the anesthetist telling you to stop and let me ventilate, and then you have a big tube in your way. But again, depends. If not, you can use the conventional ventilation. All you have to do is to make sure that you actually remove the tube and put it back in, as anesthetist will tell you. Cardiopulmonary bypass and ECMO, it looks very appealing because nothing is in the way and you can just carry on with the operation. But the problem is, as I said, anticoagulation, bleeding, lung injury, and we really never have used either of these adjuncts. Teamwork is teamwork in this one. Okay, you want really good anesthetist, you want good nurse, and a really good assistant. and you should all communicate with each other. So when you are having on table ventilation, you need a good tube, and make sure the tube stays above the carina, doesn't go on one side, and don't overinflate the balloon. Okay, preserve the blood supply and make sure the airway remains clean, the blood doesn't go in. So resect through the healthy trachea, and then once the trachea has been resected, the tube has gone distally, and then you start repairing it. And it's again your choice, continuous, interrupted, or continuous, interrupted, whatever you want to use. At the end of the day, nicely placed sutures, and they should be airtight. And then how you mobilize the trachea, that's all written in the books. It's not difficult, but I always advise is to not put your finger laterally. Okay, that's where the blood supply is. Anteriorly, go right up to the carina with your long finger, and that gives lots and lots of mobilization. Release procedures again. If you have to use it, but you need to consent the patient because they do cause post-operative problems, particularly aspiration to begin with. So this is a simple one. You can see this was a post-intubation stricture lower down. This is the head end of the patient, and you have removed it. Really nice lumen. You just get the two ends together. This is the ones which I was talking about, the idiopathic one, and you can see in this one that is the cricoid area, and you see the narrowing there. And if you look at it, this is the cricoid plate anteriorly removed. That's the vocal cords, and the anastomosis is going to be just there. Okay, sorry. And then, as I said, that this is what I was talking about, that when you are tying these ones, you need to flex the neck, take the shoulder bag out, and you make sure that all that doesn't get entangled. So this is the one which I showed you earlier with a complete transection. And the problem with this is never expect you'll go in and it'll be there and you cut it. No, it will be complete mess. Somebody to have that sort of picture, somewhere there you will not find anything. So you can see that is the trachea we eventually managed to find, and that is something a really difficult. Uh, the first bit is difficult, is to find the trachea, but once you find the trachea, then the rest is a breeze. So next 3-4 minutes, I'll just talk about the tumors. So majority of the tumors which you find which are resectable will either be adenoid cystic, rarely carcinoids, and very rarely this sort of a tumor, which is actually a chondrosarcoma. Now, the important thing here is with these tumors is that if patient is breathing, when the patient comes to you with that sort of a tumor, it's better to send the patient straight away to the place where this can be dealt with, because the problem is that once you start disrupting it, you don't know what it is and what damage it is causing. Number one. Number two, if you are very, very good and you completely take it out and it turns out to be some sort of malignancy where you go back and you may not be able to find where it was, and you may struggle to resect that area. And number three is that if it is indeed a sarcoma or indeed a cancer where a multidisciplinary approach is required, then you need to get those people involved. And the other thing what can happen is, for example, in this one, this is another tumor, and they actually did a tracheostomy through the tumor. So that creates more problem, because not only the amount of trachea which now needs to be required has extended because of that damage, but also there's a possibility that this tumor may have seeded. So just be mindful, because these are such a rare tumors that we all need to be together when we are managing. I can't claim I have got experience to teach anybody about this, but if we are all together, we may all learn together, and we may serve the patient better. So collaboration amongst each other is what is required for these cases. And similarly, this is the one where it is sitting just above the carina, and again, this is adenoid cystic carcinoma. So all you have to do is take a biopsy, and if the patient is breathing, leave him alone and prepare him for surgery. And that's because it is so lower down, so it required a high thoracotomy, right-sided, and you deal with it. And again, the question asked many a times is median sternotomy or high thoracotomy. I will probably go with, unless you are doing a carinal resection, I will prefer high upper thoracotomy. And that's what it is. So you can see from the thoracotomy how good exposure you can get. Even if you have to take a carina out, it can be repaired through the thoracotomy. But if you want to really go in and go further distal, like for example in this page where there's a carinal resection, we will probably approach through the median sternotomy. Once you have done the operation, that is the most important bit, that you need an extubated patient with a patent airway. So gentle emergence, avoid violent coughing and movement, and then why you extubate. A lot of people ask this question again, but I think that is the best way to manage these patients because tube will irritate the anastomosis, and the positive pressure ventilation is strain on the suture line, and it's better out. Chin stitch, must talk to the patient before you do that, because patient, if find a chin stitch after the surgery and didn't know about it, he will not take it nicely. And if the patient doesn't breathe, then what? Then just go one by one, explore the cause. Is it enough respiratory drive or muscle strength? Is there some blood or stuff distally which is causing problem? And then if need be, you can prophylactically do either intubation or you can perform a tracheostomy. And if you are really doing that subglottic sort of a anastomosis just next to the vocal cords, there will be vocal cord edema. Just put a T-tube for a few days. So the crucial periods is apneic spells, tube migrating to one of the sides, and make sure you keep clearing the bloods. Post-operatively, first 24 hours on HTU, I have made them nil by mouth for a couple of days before the salt assessment. And this is important because especially with the subglottic ones, the patient's chin next to the sternum, it's difficult for them to swallow. And this is what the laryngotracheal resection looks like. You can see that is the mini tracheostomy tube there, just next to the vocal cord. So the anastomosis has just been made there. And this is what you will find, that actually posteriorly, this is the posterior, this is anterior, this is the epiglottis, that there is always a bit of opening there. Okay, and that's why the patients can have change in voice and can struggle to breathe. This is an ideal post-tracheostomy repair and outcome. I don't have time left for Tracheobronchomalacia, so maybe next year when we see you guys, I'll give you a lecture on this. This is a very exciting topic as well. So thank you very much for listening to me. I'll take questions at the end.